We have, according to SAMHSA data, 12 million adult Americans in 2019. If we add in the YRBS data from the CDC for the Youth Risk Behavior Survey, we may be looking at 2 million more. It's 14 million Americans in 2019 who had serious thoughts of suicide. Our work is cut out for us to really try to go after suicidal thinking. If we were better upstream in identifying and treating suicidal ideation, we'd have fewer attempts and fewer completions downstream. So I really want us as mental health care providers to think about this massive population. 4.7% of the American adult population with serious suicidal thoughts. We can identify these individuals, we can treat these individuals, and they don't have to go on to take their lives.
When we began this journey many years ago at Kaiser Permanente, Washington, there was certainly a concern that identifying suicide risk would somehow create some liability or place some excess burden on primary care and mental health providers. And some of our healthcare systems leaders were talking about maybe we should just adopt a don't ask policy about thoughts of self-harm.
I really want to demystify this notion that, that we can't work with suicide risk or people in crisis in a remote way. Of course we can. It's just a matter of being thoughtful about it. A don't ask approach to saving lives is not going to be effective.
We certainly know that asking about risk of self-harm does not create or increase risk. It simply reveals risk that was already there and risk that we should know about. We also now know that very simple methods, simple questionnaires, several of them can accurately identify people who are at high risk for suicide attempt or even dying by suicide. So screening at healthcare settings is an important way to identify people who are at risk, especially people we may not have known about. This is an important prevention opportunity. We should be asking about risk of suicide the same way we ask about other things that we screen for. What we're trying to do is not to identify the person who is in the midst of some suicidal act. We're trying to identify the person who is at high risk over the next several weeks or months when we might be able to intervene effectively. When I talk to my general medical colleagues, the analogy I often use is asking every primary care patient about thoughts of death or self-harm is not like doing the electrocardiogram for chest pain in the emergency room. It's about measuring blood sugar in people with diabetes, or it's about measuring blood pressure in people with heart disease. It's trying to identify the people who we know are at high risk and will continue to be at high risk over the next few months. So we might be able to put in place safety plans and interventions that will address that risk.